Okay, so without further ado, let's get going. So we're going to talk today about management of wide complex tachycardia in the emergency department, a rational approach to sorting out what's going on as well as what to do about it. Otherwise known as it's wide and fast, yikes, what should I do? So I have no disclosures nor conflicts to declare. And in today's talk, we're going to review the differential diagnosis of wide complex tachycardia. We're going to look at some ECG criteria that is useful in distinguishing VT from SVT with aberrant conduction. We'll briefly mention the existing decision tools, or at least the primary ones that are out there. And then we'll end with an algorithm that I have used and developed with the assistance of others that I think is rational, makes sense, and is pretty easy to do, and almost always ends with doing the right thing for the patient, which of course is the most important thing. So wide complex tachycardia, it's a challenging clinical presentation in the ED, and many of us, myself included, sometimes get way too worried about it, okay? Yet, when you think about it and you step back and look at the situation, common medical sense, coupled with a rational approach to management, almost always yields the correct approach to the patient regarding diagnosing and managing. Now, you may not always be able to clinch the diagnosis of the specific dysrhythmia in the first 5-10 minutes, and that doesn't mean you're a bad doctor or not up to date on the literature or have poor ECG interpretation skills. No, none of that is the case. Sometimes it's not possible to make the rhythm diagnosis initially, whether you're an emergency physician, a cardiologist, including an electrophysiologist. Sometimes you need to move on and treat the patient in the setting of the ECG and not just the ECG. When in doubt, let's assume that it's ventricular tachycardia. That's true in most cases, but there's a couple entities in this differential diagnosis that we need to exclude, and we'll go over those. So this is the way I approach management of wide complex tachycardia, both from a diagnostic perspective as well as a treatment perspective. But before we get to this, let's kind of review some background first. So here's the differential diagnosis in a graphical sense. VT and SVT with aberrant conduction. The SVT with aberrant conduction includes many different dysrhythmias. The ones that I've placed at the bottom of the screen are the more common ones that we encounter in the emergency department, okay? So there are other entities out there, but these are the most common ones. And when you look at older ED literature, including some of the previous textbooks in emergency medicine, we had been told that a wide complex tachycardia patient, VT is most often the diagnosis 80% of the time, and SVT with aberrant conduction. But anytime you see the phrase classically or traditionally reported, that's a big warning that that's not really what the current state is. And in fact, when you look at data around the United States, Canada, Europe, Asia, the rest of the world, the opposite is in fact the case. The vast majority of wide complex tachycardia cases that we manage in the emergency department is SVT with aberrancy, and a minority are in fact ventricular tachycardia. So where does this discrepancy come from? Well, the older reports in the EM literature were based more on CCU and electrophysiology laboratory populations, where, yeah, most of those patients have recalcitrant ventricular tachycardia, and they end up in the CCU or the EP lab for further diagnosis and management. So not surprisingly, most wide complex tachycardia cases in the EP lab are VT, but we don't work in the EP lab. Okay? We don't work in the CCU. We work in the emergency department. So our world is a little bit different. Okay? The majority of wide complex tachycardia patients you're going to care for in your ED are SVT with aberrant conduction. So let's now briefly define what each of these two broad entities is. SVT with aberrant conduction, it's a tachycardia with a focus in the supraventricular area. Okay, SA node, AV node, atrial tissues, somewhere supraventricular. And the QRS complex is widened because of some abnormality of conduction in the ventricle. A bundle branch block, which is either a fixed pre-existing entity or perhaps a rate-related bundle branch block. You can have toxic effects. You can have metabolic effects. And of course, in the uncommon situation, you can have accessory atrioventricular pathway issues such as in Wolff-Parkinson-White syndrome. But the supraventricular focus coupled with abnormal conduction in the ventricle results in a wide complex tachycardia. So graphically, we have the focus somewhere in the supraventricular tissues occurring in the setting of abnormal conduction in the ventricle that then results in a rapid, wide complex dysrhythmia, the wide complex tachycardia. Okay. And again, the differential diagnosis is rather broad. Sinus tachycardia with bundle branch block. Sinus tachycardia with some sort of toxin on board, particularly sodium channel blockers that will widen the QRS complex. Sinus tachycardia with hyperkalemia. Okay. Atrial fibrillation with bundle branch block. AV NRT, or what we tend to refer to as PSVT with bundle branch block. AFib with WPW, and the very uncommon intradromic AVRT in the setting of WPW. These are the more common SVT with aberrant conduction entities, and of course there are others. Now, let's look at VT quickly. VT, I think we're all pretty comfortable with, okay, at least what it means and how it presents. We have a focus somewhere in the ventricular myocardium. The intraventricular conduction system, the bundle of His, the bundle branches aren't used to conduct the impulse through the ventricle, so we have inefficient conduction that takes much longer to occur, and we have the resultant wide complex tachycardia, which you then put together with the ventricular focus, and we have VT. So graphically again, focus in the ventricle, the conduction system is not being employed, and we have the resultant rapid, regular, wide, complex rhythm. Now, VT itself can present in a number of different ways electrocardiographically to us, most commonly monomorphic VT, where all QRS complexes are similar, if not the same in any given lead. Rate typically about 170, QRS complex is widened, and again, this represents about 75, maybe 80% of the VT we see in the emergency medical world. Polymorphic VTAC has a much more varied presentation with varying QRS morphologies in any given lead and a more rapid rate. Polymorphic VT represents about 20 to maybe 30% of VT we see in our emergency medical world. And of course, torsade, and for the French-speaking personnel on the talk today, I apologize for my lack of pronunciation, but torsade itself is a subtype of polymorphic VTAC diagnosed with the characteristic twisting about the points QRS morphology, and in a patient when they're in sinus rhythm, either pre or post arrest, having a QTC interval greater than 450 milliseconds. So now let's move into making the distinction. Is this VT or is this an SVT with aberrant conduction? Clinical information is really helpful only in a secondary or maybe even tertiary sense. Okay. Increasing age in general is associated with increasing incidence of VT. But again, that doesn't mean that older people always have VT and younger people always have SVT with aberrant conduction. We do see from the literature in a somewhat weak statement that age less than 50 tends to favor SVT with aberrant conduction, and age greater than 50 tends to favor VT. But again, please do not make your ECG rhythm diagnosis based on age. Age is secondary or tertiary at best in terms of supporting information. Past medical history is potentially worthwhile. Congenital heart disease early in life with surgery favors SVT with aberrancy. And remember, congenital heart disease surgery frequently disrupts the right bundle, producing a fixed or permanent bundle branch block pattern. On the other hand, multivessel coronary disease, past MI, past current significant chronic heart failure favors VT. A sick left ventricle is the perfect substrate for VT to occur. So when you begin to put age and medical history together, you get a little bit more useful supporting information clinically. But again, don't base your diagnosis on either of these or even both together. And very importantly, symptoms and signs aren't helpful. Some clinicians, of course none of us, feel that patients that are very ill on presentation, hypotensive, syncope, really don't look so good, okay? That's VT. And on the other hand, people that are not hypotensive, that are not as ill on presentation, must be SVT with aberrant conduction. And those two statements are 100% incorrect. Okay? In fact, signs and symptoms are not helpful in making the distinction. So you will see, and you probably have seen, patients with VT that are tolerating the rhythm, and patients with SVT with aberrant conduction who are very sick. So let's now move into a couple ECG issues that we can potentially consider. Now, I mentioned rate because a lot of people tend to focus on rate, but ventricular rate is not helpful, repeating, not helpful in making the distinction between SVT with aberrant conduction and VT. In general, SVT tends to be a little bit faster than VT, but there's so much overlap in the rate ranges that you really can't use rate to make a distinction between one rhythm category and the other. So no value, disregard it with respect to making the call SVT with aberrancy versus VT. Regularity, most of the time, is also not helpful. Most of the time. Now, VT is usually very regular, particularly monomorphic VT, which is what we usually see in clinical practice. SVT with aberrant conduction, regular, but there are a couple of important irregular varieties, namely atrial fibrillation and multifocal atrial tachycardia. If both of these present to us with a bundle branch block pattern, you will have an irregular wide complex tachycardia. And when irregularity is present and we don't feel that polymorphic VT is present, in other words, the QRS complexes all look very similar to one another in any given lead, then we probably have an SVT with aberrant conduction involving atrial fibrillation or multifocal atrial tachycardia. Now, here we're going to talk about several different findings that are actually quite useful. One of them is AVD dissociation. Now, remember, when a patient goes into ventricular tachycardia, that doesn't mean the SA node shuts down and stops working. In fact, the SA node frequently continues to depolarize, producing atrial depolarization and a P wave. On occasion, you will see these P waves appearing in the otherwise wide, rapid, regular, complex rhythm. That indicates AV dissociation, and when you see it, it strongly favors a diagnosis of ventricular tachycardia. So as we can see in this rhythm strip, we have a rapid, regular, wide, complex rhythm, okay, looks and acts like VT, and then these occasionally small appearing deflections or P waves, that's AV dissociation. And when you see it, you can rule in VT to a pretty high degree of certainty. The literature tells us that this finding is in fact not very common. I politely and respectfully disagree with the literature and feel that this actually does occur more often than is suggested by the various publications. Certainly not every day, not every case, but if you know to look for it and you have the patience to look for it, you will see it more often than not. And when you see it, your wide complex tachycardia is likely, very likely, ventricular tachycardia. Here's a 12-lead electrocardiogram with a rapid, wide complex rhythm, as we can see down here in the lead 2 rhythm strip. And then in selected areas where the big black arrows are indicating little small deflections, these are probably P waves, and that represents AV dissociation, giving very strong electrocardiographic evidence that this wide complex tachycardia is ventricular tachycardia. So look for it, it's out there, and when you see it, it is quite helpful. Now, continuing on with this concept of AV dissociation, we're now going to mention fusion and capture beats. Again, remember, when a patient goes into ventricular tachycardia, they have the ventricular focus firing off at regular intervals, producing the VT. But again, remember, the SA node continues to electrically discharge, causing depolarization of the atria. Okay, that can produce AV dissociation, as we've just seen, but it can also produce other findings, which are the fusion and capture beat. Okay, so what is a fusion beat? A fusion beat is a supraventricular impulse, most of the time from the SA node, that makes its way through the atrial tissues into the AV node, into the ventricle, and causes ventricular depolarization at the exact same instant that the VT focus is causing ventricular depolarization. So these two depolarization waves fuse at the level of the ventricle and cause an intermediate width QRS complex. Not a nice, normal, narrow QRS like the patients in sinus rhythm, but certainly not these wide, evil-looking wide complexes of VT. So the QRS complex is a fusion and an intermediate width resulting from the supraventricular impulse and the ventricular impulse, producing this nice intermediate width QRS complex. A capture beat is the exact same idea, except it goes a step further, where the SA node captures the ventricle electrically for that one beat, where the impulse makes its way through the AV node into the ventricle, causing ventricular depolarization prior to the VT focus firing off, and it produces a nice normal appearing beat. In fact, you can see a P wave with a narrow QRS and a T wave, and then you have these evil wide complexes representative of VT. Either of these beats, fusion beats or capture beats, if you see them, strongly favors VT. Again, the literature tells us this is not very common. Again, I respectfully disagree with the literature. It's not an everyday event in your VT patients, but it does occur more often than we think. And again, if you know what to look for and have the patients to look for it, either AV dissociation or fusion capture beats are present, and when present, strongly suggests the diagnosis of VT. Here's a multi-channel rhythm strip involving leads 1, AVL, and V1, where we see both. Right? We have a rapid, regular, wide, complex rhythm in a 60-year-old female, history of multivessel coronary disease and past MI, coming in with a wide, complex rhythm that she's tolerating. She's awake, alert, good blood pressure, no chest pain, not in respiratory failure. So we've got a little bit of time to sort this out. And in fact, looking at this multi-channel rhythm strip, we see both of these beats. We see an intermediate width QRS complex occurring and a narrow QRS complex occurring. Okay, this is the capture beat and this is the fusion beat. Either of these strongly suggests VT. Both of them, you've got VT. Now, the third issue I want to mention briefly is the concept of precordial concordance. This refers to the polarity of the QRS complexes in the wide complex rhythm. You tend to have positive precordial concordance when all the QRS complexes are positive or mostly positive, and you have negative concordance when the QRS complexes are all or mostly negative from V1 to V6. So examples here. Here's positive concordance going from V1 to V6, where the QRS complexes are primarily positive across the precordial leads, and down below, negative concordance, where they're in fact entirely negative from V1 to V6. Why is this important? Well, if you see positive concordance, that frequently is VT, and negative concordance is almost always VT. So again, high value ECG findings that you should consider and look for. Of course, the absence of concordance, like many things in medicine, doesn't rule out VT, but its presence can suggest it. So real briefly, let's mention why this can occur. Now, here's a patient in sinus rhythm, not a wide complex tachycardia. And remember, lead V1 is almost always entirely negative or mostly negative. And as we go from V2 to V3 all the way out to V6, we have progressively more positive component of the QRS, the R wave, and progressively less Q or S wave, the negative component of the QRS, such by the time we arrive at V6, we have an entirely positive QRS complex. This suggests a supraventricular source of the rhythm, okay? And here's a patient in over time. This is when he's in sinus rhythm with normal conduction in the ventricle, again, with a normal R wave progression going from small to very large R wave, negative to positive QRS complex as we go across the precordial leads. When the patient has developed this left bundle branch block pattern while still in sinus rhythm, we see pretty much the same progression of QRS complex from mostly negative to mostly positive when we go to V1 to V6. And the only difference here, of course, is the QRS complex, which is wider. So this really suggests, obviously, a supraventricular source of the rhythm focus when the patient's in sinus rhythm. And so if the patient then develops a tachycardia, that's where the concordance issues can come into play and be helpful. Up top in the left of your slide is a patient in a wide complex rhythm with positive concordance, where the QRS complexes are primarily positive from V1 to V6, and down below in the lower right, negative concordance, where the QRS complexes are entirely negative from V1 to V6. When present, this does not suggest a supraventricular rhythm focus or source of the rhythm. It, in fact, suggests a ventricular source. Remember, positive concordance frequently is VT, and negative concordance is almost always VT. So this finding, in addition to the other three that I've mentioned, are quite helpful. Now, the next range of findings are not particularly helpful. So QRS width, QRS axis, morphologies, contours, combination of features. These are findings that really comprise many of the clinical decision rules we're going to next mention, and they're not that helpful, okay? They take up a lot of brain space, they're difficult to apply, they're difficult to remember, and they're not particularly accurate. There's too many ifs and thens and buts and yets and that sort of thing. So I really don't suggest that the emergency physician should consider these. Certainly the cardiologist, certainly the electrophysiologist, they use these, and that's appropriate. That's their world, but that's a different world from which we work. Right? And here are really the 5 well-known decision rules, starting in 1978 and going up to about 2011. There are others out there. They're not as well known, but these are representative of suggested decision rules looking at SVT with aberrancy versus VT. And frankly, none of them are particularly accurate. They're quite accurate when used by the cardiologists that have developed them, the electrophysiology world. But when you take these rules and apply them outside of that world, they're less accurate. They don't work as well. And there's a fair amount of variation in the way internal medicine doctors, family medicine doctors, intensivist doctors, emergency doctors use them. So this variation, this lack of accuracy is somewhat troubling and not particularly of value. A paper in 2012 actually compared the diagnostic accuracy of each of these rules and really found that the older rules didn't function really any better than the newer rules. And, so what are some of the issues here? First of all, these are all written by cardiologists who are very knowledgeable and truly experts in rhythm diagnosis and management. But most of these rhythms were VT in these data sets. SVT with aberrancy wasn't represented to the extent that we see it in the emergency department. So these rules really weren't developed in the setting of the emergency department. In fact, they were developed for CCU and electrophysiology laboratory use. Several of them also have a default diagnosis of SVT with aberrancy, for example, the Brugada algorithm. And as an emergency physicians, we are very cautious and always assume the worst. Let's not assume that the less serious entity is causing the rhythm when in fact it is VT. All right, so let's move into the algorithm here in conclusion. This is the way I think, and this I think is reflective of the literature to the extent that it's helpful for the emergency physician. So let's go through it step by step. You walk into the room and you're taking care of a patient with a wide complex tachycardia. Of course, you're going to be looking at the electrocardiogram, whether it's the monitor, whether it's a 12-lead ECG or some other variant of ECG information that's given to you. You're also, of course, going to be looking at the patient. Is the patient stable? Is the patient unstable? Is the patient tolerating this dysrhythmia, et cetera, et cetera? In the differential diagnosis, we need to identify and exclude sinus tachycardia with bundle branch block, sinus tachycardia with hyperkalemia and a widened QRS complex, and sinus tachycardia resulting from various toxic rhythms. We need to identify these dysrhythmias and treat the underlying issue or issues. Okay. Once we do that, then the differential becomes much more focused and includes AVRT, which is the wide complex rhythm of WPW, AVNRT, which we tend to refer to as PSVT, certainly AFib and A-flutter with bundle branch, and of course VT. That's what's left in the differential diagnosis once we exclude the sinus TAC variants with widened QRS complex. One suggestion here is that if we have atrial fibrillation or atrial flutter with rapid ventricular response occurring in a complex situation such as septic shock, pulmonary embolus, et cetera, we're likely going to want to focus initially on treating the underlying issue and not necessarily going immediately to rhythm control. Okay, so we want to exclude that and at least initially approach that rhythm disturbance a bit differently. So when we do that, we're now left with AVNRT, okay, AVRT, AFib, A-flutter, all with bundle branch block, and VT. So let's treat the rhythm according to the clinical presentation and patient stability. If we can identify the underlying rhythm, that's fine. But if we can't sort out what the rhythm is once we've excluded these other entities, then let's assume it's VT and treat appropriately, which can include synchronized electrical cardioversion with sedation if the patient's unstable, or we feel that's the best approach. And then also procainamide, as Dr. Steele mentioned. Procainamide is an awesome drug, and it's really underused. 17 milligram per kilogram maximum load. Its only failing is that you can't give it rapidly because it'll promote hypotension. So we need to be careful with it, but it is a very excellent drug that we need to think about and use more often than, frankly, most of us do. So, in summary, wide complex tachycardia, focus on the patient and the electrocardiogram and not just the ECG. Treat the total presentation as we always do as emergency physicians. Remember that VTAC occurs in older patients with compromised left ventricles, meaning multivessel coronary disease, meaning chronic significant heart failure, meaning past MI. But so does SVT with aberrant conduction, and in fact, probably more frequently than VT does. Recognize that sinus TAC with bundle branch block, hyperkalemia, and toxic effects occur, and if we can exclude those from the differential and treat them accordingly based on the underlying issue, the rhythms that we're left with can all be treated with synchronized electrical cardioversion and/or intravenous procainamide. So this is a challenging presentation, but we all, myself included, make it much more challenging than it truly need be. Well, thank you all. My email address is right here. Please, if you have any questions that are not answered today, reach out. Love to hear from you. And of course, any amazing ECGs, please send them my way. Thanks for what you do. And particularly, thanks for what you're doing during all this COVID craziness. Thank you.
All right. Bill, thanks so much. That was a really fantastic talk. I think we have a few minutes for questions, and then we'll take our break. So let me hand things over to Sarah and Cheyenne for a couple of questions that have come up on the chat.
Okay.
Thank you, Dr. Brady. So first question for you is there any way to increase the sensitivity of the EKG in capturing AV dissociation, fusion beats, or capture beats?
Yeah, great question. And yes, there is. So we can certainly manipulate the electrocardiographic appearance by increasing the rate and increasing the amplitude of the structure. So if you increase the rate, most ECG machines, most monitor machines that are preset default setting at 25 millimeters per second, if you double that to 50, what you're going to do is pull the ECG structures apart on the monitor and on the paper. And if you have a small P wave, for example, that's lost because the QRS complexes are near overlapping on one another, by doubling the rate, you're going to separate those structures, those QRS complexes, much, much more, and you may see a small P wave in between. Also, if you increase the amplitude to maybe 2 to 4 times the default setting, then you will detect these smaller P waves much more reliably. If you do that and you print out an electrocardiogram, make sure you label it appropriately so that somebody doesn't come along and think, what is this? What rhythm is going on here? Why do they think this is VT? Okay, it looks more like, so just make sure you label the ECG appropriately, but great question.
Thank you so much, Dr. Brady. So we have a question actually from one of our other speakers, Dr. Steele, for you. What is the role of vagal maneuvers and adenosine in managing a stable patient with wide complex tachycardia if it's not WPW?
Yes, another great question. And we've seen the guidelines, at least HA guidelines, varying in this really over the last 20 years. Early on, adenosine was recommended in the undifferentiated wide complex tachycardia, aiming at the entity of SVT with aberrant conduction, namely AV-NRT. The guidelines then backed off a little bit and made a notation that the WPW antidromic AV-RT, the wide complex rhythm of WPW, could be harmed in this setting by using AV node blocking agents. Now the guidelines are somewhere in between and suggest that it's a potential drug that can be used. Remember that adenosine is an awesome drug for AV-NRT and will convert probably 80 to 90% of these rhythm presentations without any problem. But I would suggest that in the setting of SVT with aberrant conduction, AV-NRT is not a very common dysrhythmia. So we're using a drug for one of the much less common dysrhythmias. And also, Mother Nature has thrown us a curveball here. There is a form of VT that's adenosine sensitive. And in fact, so you could come along and treat this stable wide complex tachycardia with appropriate doses of adenosine, convert the patient and say, whoa, this must be AV-NRT or PSVT with a bundle branch block, when in fact it was VT, and not recognize your patient just had VT. So it is certainly not a wrong thing to do. I would suggest that utility is much less valuable than, say, some other interventions. And it can lead you, uncommonly, I agree, but it can lead you down the wrong diagnostic pathway.
All right. Once again, Bill, thanks so much for your time. We're going to, at this point, we're going to take about a 15-minute break. So back here on the East Coast, it's 9:50, and we will resume with Dr. Slovis at 10:05. So we'll be back in 15 minutes. So again, a chance for everybody to refill their coffee or wine, depending on what part of the world you're in. Just before we leave, just one quick note. People have been putting a lot of tweets out there in the Twitterverse. Our hashtag for this conference is hashtag ECS21, which we recently discovered also is a shared hashtag with the European Cricket Society. So we're really trying to overwhelm the cricket players by tweeting out more than they're tweeting. So if you have any great pearls you want to share with the world, again, hashtag ECS21. All right, folks, see you back in 15 minutes.
Dr. Matu, thanks for the opportunity to speak. And of course, I would also like to thank members of the European Cricket Society for their attention today.
Fantastic. Thanks.